Hi, my name is Sean Runnels, and I'm an associate professor of anesthesiology at the University of Utah in the United States. I'm also the CEO of Through the Cords, or ttcmed.com. Today we're going to talk about intubation failure with video laryngoscopes. And I'm going to use a model of visualization and tracheal access component co-evolution to try to explain and further the understanding of why we fail with video laryngoscopes. So the objectives of the lecture: I want you to understand that intubation is evolving. Intubation is a system of components, or at least that's the way I think of intubation. And we want to understand why intubations fail. Understand that there's models for intubation geometry, and they're changing, and they should change as we shift from direct laryngoscopy to video laryngoscopy. And we're going to talk about combined technique, which is a very powerful technique to intubate people with difficult airways. Disclosures: I'm the inventor of the TCI dynamic introducer. I'm the CEO of Through the Cords, or TTC Med. And my bias is that access to safe intubation should be available to all people in all medical systems. I spent 3 years working in Africa, the first in Guinea, with Mercy Ships, which is a floating hospital ship. 6 operating rooms, 90 ward beds. That allowed us to do major surgery and get excellent outcomes. I was one of the continuity anesthesiologists for a year. Others were coming to help 2 to 3 weeks at a time. These are the sorts of airways we were managing. These are max-fax cases, very difficult intubations to manage. Initially, I was using a lot of fiber optic intubation techniques, awake and asleep. At one point, we had our fiber optic bronchoscope broke. I did have disposable scope, fiber optic scopes, but there was no visualization equipment with them, so they were simply, I could articulate the tips, and I used them as steerable introducers. So VL for visualization, fiber optic bronch repurposed as a dynamic or steerable introducer, and I found that if I could see with a video laryngoscope, suddenly I could steer with the introducer, I could access most any trachea. And very simply, easy to learn technique, easy to teach, intuitive, and effective. Very consistent outcomes. So video laryngoscopy for visualization, fiber is put through the nose or the mouth. When it appears in the field of view of the video laryngoscope, you can now drive it. You can precisely navigate into the trachea around anatomy and around curves. You can see that I'm not quite through the glottis, so I can move over and down, still pointing to anteriorly, so now I can navigate downwards and in it goes. Once I'm in the trachea, I have a secure route to the trachea, and now I can railroad the endotracheal tube over the introducer and into the trachea. A very effective technique. I would encourage all of you to use it. Key models for intubation. This is the intubation modeling I use when I teach residents. Intubation is a process, a 2-step process. Intubation is achieved with a system of 3 components. And largely, when I teach intubation, I think of solving geometry problems. And we talk a lot about dynamic versus static tracheal access with video laryngoscopy. Intubation is a process. The vast majority of intubations follow the process of visualize the glottis. Once the glottis is visualized, access the trachea. We do this with a system, an intubation system. And in my world, the system has three components. It's got visualization equipment, it's got tracheal access equipment, and then it's got an operator that controls those two equipment components. Intubation system, we can use direct laryngoscopy or video laryngoscopy to visualize the glottis. We can use static tracheal access. In fact, most of intubation history has been static tracheal access. And by static, I mean once the shape of the access tool is chosen, you cannot change that shape or that curve while in use. Now, more recently, dynamic introducers have been introduced, including my TCI dynamic introducer, that allows you to change shape or steer through the airway. And then there's the operator. We can have a single operator system or a double operator system. We're going to come back to this system model a few times in this talk. Okay, the geometry problem of intubation. This is a cross-section of the natural human airway. Ken Greenland introduced a very nice model in 2010. This model has not been widely disseminated, so I would encourage you to pull this paper and disseminate this model. This model makes much more sense than the three-axis model in terms of explaining both direct laryngoscopy and video laryngoscopy. So here's the glottis. We note that there are two curves. There's a primary curve and a secondary curve to the human airway. So that's the path of the human airway. Primary curve, secondary curve. Okay, and the inflection point between these two curves is the glottis. So the key understandings of this model, two curves. The curves are in opposite directions. There's an anterior curve and a posterior curve. The inflection point from anterior to posterior is at the glottis. This is serpentine geometry or snake-like geometry. This is an icon that I'll use to represent the natural curves of the human airway throughout this talk. So now we're going to use some evolution and look at the evolution of intubation in terms of evolution of its component parts over time. So visualization components and access, tracheal access components, and they are locked in coevolution. So visualization on our top timeline and access or tracheal access on our bottom timeline. 1940 is where we started to intubate regularly. That was achieved, visualization was achieved with a direct laryngoscope. Look back at pictures from the 40s and 50s, things haven't changed much. This really is the direct laryngoscopy era. That era is still in play now. Tracheal access, rigid and malleable stylets and introducers. Key understanding is they are static. You cannot change their shape while in use. Once you bend them and choose a shape, you're stuck with it throughout the intubation. Okay, so DL era visualization, you line your eye up with the trachea, create a direct line of sight, see the glottis, and that's all linear. So this is a very linear technique. Tracheal access geometry, linear. You access the trachea down that same line of sight. Okay, models for DL era intubation, alignment of axes. This is still the predominant model that is taught across the world. All about linear geometry. Appropriate for DL, I would argue, probably not for video laryngoscopy. So 3 axes. We use our equipment to align those axes. And once they're aligned, we can access the trachea. Okay? Introduced by Bannister and Macbeth in 1944. Still the predominant model. Maybe we need to update. Okay? This is the icon. This is what the natural airway really looks like. It's 2 curves. They inflect at the glottis, and they're in opposite directions. So Greenland's model explains direct laryngoscopy by flattening of curves. The direct laryngoscope flattens the primary curve, and then lifts the jaw and tongue to flatten the secondary curve, creating a straight line to intubate with. That explains direct laryngoscopy just fine. Why do we fail with a direct laryngoscope? It's a failure of visualization. If we can't see, we can't access the trachea. So here's our DL intubation system: visualization equipment, direct laryngoscope, tracheal access equipment, static, operator, single operator. Okay, back to our timeline. Why do we fail with DL? Failure of visualization. So that failure drove evolution of the visualization component, and we ended up with the video laryngoscope. That began the VL era in 2002. Okay, how does the video laryngoscope work? Here's our curves. The video laryngoscope is shaped the same as that primary curve. We look around that primary curve up to the glottis. We really can't see the secondary curve, so we're largely unaware of it. But that look around the corner capability has produced excellent visualization of the glottis, and it's very easy to learn. Now look through those vocal cords, and you will see that secondary curve. The anterior trachea is what you see, and that's because the trachea actually turns down posteriorly towards the carina. So that's the secondary curve. But out of sight, out of mind, most of us are unaware of that, or it isn't explicitly aware of it. We know we struggle there, but we don't know why. So all good things have consequences. We look around the corner now. That's great for visualization, but the consequence is the two curves of the airway remain intact. We now have to deliver endotracheal tubes around two curves and an inflection point. So we have three problems, geometry problems. We have to solve that primary curve in the anterior direction. We have to inflect across to the posterior curve, and then we have to solve the secondary curve and move the tip in the second direction. How do we do that? This is visualization. That solves visualization. We got to add geometry to our timeline now. So geometry of DL era is linear. Geometry of VL era is serpentine. We have had some evolution in tracheal access. It's still static, but now we have a rigid glide right stylet or a rigid video laryngoscopy stylet. Does it do everything we need? Well, let's look what it does. Rigid static stylets solve the primary curve. They do not solve the secondary curve or the inflection point. So they're static. They're the shape of the curve cannot be changed while in use. It's a single anterior curve that mimics the primary curve of the airway. It solves the primary curve only. How do we solve the second curve and the third, or the inflection point? So it does not solve those. How do we solve that? We have to go from an anterior position to a posterior position. So we've got to turn this corner and get back down the trachea. We force the ET tube tip posteriorly with anterior glottic structures and anterior tracheal structures, force on tissue. This is what it can look like. Again, a little maneuverability there would be nice, but a rigid stylet doesn't really provide fine maneuverability. And then once we're in the glottis, the tip is pointing anteriorly, and we put force on the anterior glottis, and then we sometimes turn the tube around, and in we go. Okay, so a lot of force on tissue. This is what our classic VL system looks like: single operator, panoramic and stable vision from a video laryngoscope, which is great. Tracheal access equipment, mostly static. Rigid stylets that solve the primary curve only. So now our problem with video laryngoscopy is tracheal access. That's why we're failing. Back to our timeline. Tracheal access is now the predominant reason we fail. Okay, we know this through a couple of studies. This is a big multi-center randomized controlled trial of 3 different video laryngoscopes in simulated difficult airways. When there was a failure to intubate with a video laryngoscope, 76% of the time it was tracheal access problems, not visualization problems. In fact, it was quite rare that the problem was visualization. Okay, how does this problem show up clinically? I can see the cords with a video laryngoscope, but I can't deliver the tube through the cords. So key points for video laryngoscopy. Visualization is easier with a video laryngoscope, and it's superior to DL. Tracheal access geometry with a video laryngoscope is now serpentine. Static stylets solve the primary curve only, so they solve one of the geometry problems. They do not solve the other two. The shape cannot be changed while in use. The inflection point and the secondary curve, our other two geometry problems, can't be solved with the static stylet. They're solved with force on tissue. Back to our timeline: serpentine geometry, static stylet, tracheal access failure. This drove the next evolution in intubation. Access changed. We found out about dynamic introducers, and we found out that we could cross-purpose a fiber optic bronchoscope as a dynamic introducer. We didn't need its visualization capability. The VL could provide excellent visualization, and so when these two devices, VL and a fiber optic scope as a dynamic introducer, are combined, we have combined technique, and we end up with excellent results from that. So, articulating tip of a fiber optic scope and flexible shaft allows steerability through the curves of the airway. More recently, I'm developing a single operator, single-handed dynamic stylet that's purpose-built as a dynamic introducer. So, early combined technique. This is the technique I was using when I was on Mercy ships in Guinea. VL for visualization, right there. You can see that video laryngoscope is providing a big, stable, panoramic view of the glottis. And fiber optic bronchoscope used only as a dynamic introducer. Again, we're not using the optical capability, we're just using the dynamic capability. Now notice that this is a three-handed technique, which means it takes two skilled operators. So dynamic introducer, common features, whether it's a fiber optic scope or whether it's a purpose-built dynamic introducer, they must have a dynamic tip with full anterior and posterior articulation capabilities. Needs to be controlled by a handle. Flexible shaft that allows conformation to the curves of the airway. Those features allow it to solve the primary curve by articulating up and then move through the inflection point, articulating down, and solve the secondary curve. Okay, what does that look like? Here's an airway mannequin, dynamic stylet, up, primary curve solved, inflection point solved by moving the tip down, secondary curve solved, very smooth and easy to enter a trachea, precise navigation. Let's look at our combined technique when using a fiber optic bronchoscope. Tracheal access is now dynamic, but two-handed. Visualization, panoramic and stable, video laryngoscope. Because we're using a fiber optic bronchoscope, we have to coordinate two skilled operators. In some situations, a second skilled operator may not be available. Okay, the TCI dynamic introducer, key features are the same: dynamic tip, anterior and posterior articulation, handle controls the tip, flexible shaft, can solve all three geometry problems, and then the handle is removable. So that allows railroading of the endotracheal tube over the catheter. Again, flexible tip, articulation, removable handle, railroading just like a bougie. Single operator dynamic access, what's it look like or what are the steps? Endotracheal tube is loaded on the back. VL is placed. View of the glottis is obtained. Dynamic tracheal access solving all three geometry problems, primary curve, inflection point, and secondary curve. Handle is removed. Tube is railroaded into the trachea. And then the catheter is removed, leaving the endotracheal tube in place and the patient's intubated. This is what it looks like in operation. This is a woman with fused neck and limited mouth opening. She's been intubated only with fiber optics in the past. She has juvenile rheumatoid arthritis, visualization with the video laryngoscope, hyperangulated blade, primary curve solved, tip is articulated posteriorly, solving the inflection point without force, and then the secondary curve is navigated, all with a single operator. The video laryngoscope's handed off to the nurse so that the tube entry can be seen indirectly, and the patient's intubated. Very smooth, very easy, very fast, low stress for the operator, low trauma for the patient. Okay, so now what does our system look like? Left hand visualization equipment, superior video laryngoscopy view. Right hand, single-handed tracheal access, dynamic tracheal access, and a single operator technique. This is a system that is in evolutionary harmony. When we have harmony in our systems, we have good outcomes and stress-free lives. So combined technique is effective. This is a randomized controlled trial comparing video laryngoscope with a rigid stylet versus video laryngoscope with a dynamic stylet. Primary approach to difficult intubations. The fiber optic bronch was used as a blind dynamic introducer in this case. Randomized controlled trial. First attempt intubation success, 67% with a rigid stylet, 91% with a dynamic introducer. Airway trauma or injury rates, 11% with a dynamic stylet. So you can see what force on tissue to solve the inflection point and the secondary curve looks like. Now, without force on tissue and the ability to steer through, 1%. Rescue intubations, these are arguably the most difficult situations we find ourselves in. Attempts have already been made, conditions may be worsening, and it's high stress for the operators involved. Okay, so what kind of techniques are we using when we find ourselves in rescue situations? Video laryngoscopy is used quite often, and 92% success rate when used as a rescue strategy. And you can see intubating LMAs, flexible fiber optics, lighted stylets, they have less success than a video laryngoscope in the situation of rescue intubation. Okay, 92%, the flip side is 8% fail. And when you fail, then you've got to move on to these other less successful and more difficult to use techniques. So nearly 1 in 10 VL rescues fail. What about a single-handed combined technique? So this is a consecutive case series of rescue intubations using the total control introducer, dynamic introducer. 97% overall rescue success. 94% of those are on the first attempt. So where can this be used? Nasal intubations, that you saw one at the beginning of the case, or the beginning of this talk. Video laryngoscope for visualization, dynamic access through the nasal cavity, and then up over the glottis and back down the trachea. Very easy way to do nasal intubations. Importantly, there is no McGills involved with this. Awake intubations is a very powerful awake intubation technique. It's a gentleman with radiated neck and a glottic or a base of tongue tumor. This is one of my residents who's never used the device before, but I'm walking him through the technique. Video laryngoscope goes in, the patient's awake and his airway's topicalized. And because there's not a lot of force on tissue, he tolerates the procedure very well. Primary curve solved. Very intuitive visual fields to work in. Secondary curve is solved. Little coughing as we enter the trachea. Single operator up till entry of the trachea. Handle is removed. And the endotracheal tube is railroaded. Very easy technique. It's his first time. He executed it perfectly. Very easy to learn. Key points. Intubation is a system of 3 components. VL intubation geometry is changed. It's now serpentine geometry. Our models need to change to reflect that. Steerable introducers or dynamic introducers can overcome serpentine geometry. They can solve all 3 geometry problems, the primary and secondary curves, and then force-free transition of the inflection point. Combined techniques are best for most difficult intubations. They have higher first pass rates, less trauma to the patients, faster intubation times,